The next speaker is Dr. Vishal Gupta, and he's talking on Twincretins Shift the Goal from weight loss to Issue Selective weight loss. He has several published articles and chapters in diabetes textbooks, and we look forward to hearing from him about this topic.
I'm going to basically be opening the doors to two very new concepts with the GLPs. So again, this was a talk thrusted upon me because one of my dear friends, Dr. Prateet Samdani, had an extended in-laws weekend. And then I took the opportunity to discuss two aspects of the GLPs. You see, the data that we get and the data that we apply from the West to the Indians are literally comparing bananas with apples. And I'll show you as we go on why is that so. I think all of you remember me from last year, right? I think what are you seeing? What is the difference you're seeing with me? So I'm on 15 days of 7.2 milligrams of semaglutide, and I'm on 15 days of 25 milligrams of tirzepatide. I want to highlight two things. There are no treatment failures. It is the trial that has not reached the right dose in the person, and they call them a treatment failure. So if I had stuck to 15 milligrams and 2.4, I wouldn't have lost a kilogram. Muscle mass loss is a realistic story. If I was shoulder pressing 55 kilos at 110 kilos, 111, I now shoulder press 45 kilos at 88 kilos of weight. I've dropped 10 kilos of power, but my muscle to power ratio has gone up by 8%. What the catches here are muscle loss. In this journey, I'm going to make you look at diabetes so I'm going to talk about the Indian diabetic. In this room, each one of us, maybe me not today, maybe not Aisha and Vaishali because I put them also on tirzepatide. But in this room, you're all going to look at yourselves as sarcopenic and obese. I'll explain to you how as we move along. Muscle loss is a very realistic story which you need to protect. You need to be very cautious when you use this class of drugs. On the other hand, a fantastic class of drugs, but you should know how to use it. So, I want all of you to use me as your benchmark when we are going ahead with this story. So what we're going to do is, first is the outline. Let's talk about obesity. We know the Americans and the cardiologists, and I was speaking to Dr. Sethi yesterday, that the diabetic associations have now included obesity as a risk factor and a potent risk factor. I always tell everybody, do not forget the two most important risk factors which we tend to forget when patients are coming to us. One is the word 50 years of age is a catastrophe, and somebody who's harboring disease for more than 7 years. I tell everybody is that disease has gripped you from inside. So when we are discussing the outline, we talk about obesity. We talk about the obese Asian, which is a sarcopenic Asian. We redefine triglycerides. All of you, what do you all think? What do you all think a laboratory triglyceride is? Is it 100? Is it 128? Is it 130? Or is it 180? What would you think a triglyceride, a normal triglyceride is? Anyone for less than 100? Okay, so raise of hands. Less than 100? Less than 128? So we have three, four for less than 128. Less than 130? We have 1, 2, 3. Less than 150? Okay. Less than 200? I'll tell you why this 200, because the cardiologists believe that after 200, all the crap happens to the heart and the pancreas. So the cardiologists, they want it at 200, right? Sir. Yes. Oh. I want it to be less than my HDL. Okay. You want it to be less than your HDL. Okay, fine. We'll take that to our next discussion. I think we are going to redefine the triglycerides in the Indian story, right? So we'll come to those numbers. Vaishali, come here. I want you to look at the body in two ways. If somebody is on the larger side, is fat more than the muscle? Or is muscle less than the fat? And I'll show you the correlation of how both are interdependent. The role of GLP in this particular class of patients, the sarcopenic, diabetic obesity, how do we improve sarcopenia? I want to take you through a case, and Dr. Vaishali will take you through the case.
Good morning, everyone. Good morning, everyone. We have a 57-year-old whose weight is 72 kilos, with an A1C coming into the clinic with an A1C of 8.2. Look at his waist circumference. As sir said, we are talking about an Indian diabetic. Waist circumference of 98 centimeters. On metformin, a standard treatment, a metformin of 2 gram per day, glimepiride 6 milligram. He is on as SGLT2 and a gliptin optimal dose. He had a fall. He had 2 falls in last 2 years and was very unsteady. Now look at his fasting sugars of 120. It is at 8 a.m. in the morning. His postprandial sugars of 210 and post-lunch sugars of 230. His serum triglycerides 190 above. He is on rosuvastatin fenofibrate. LDL 69. 69. ApoB not optimized at 86. His HSCRP not optimized at 8.9. He is on blood pressure medication for years now. Amlodipine 10 milligram on beta blocker 50 milligrams. He is a 57-year-old male. So beta blocker 50 milligram per day. Telmisartan hydrochlorothiazide in a diabetic on SGLT2 40 by 12.5. TSH 3.2 not addressed, a UACR of 23, EGFR is 82. His NT-proBNP is 112 and a tropi of 10. Again, he is 57 years of age. His liver enzymes are SGPT of 43, 39 of SGOT and a gamma GT of 45. Now, what is highlighting in this case is his fasting triglycerides. Sir has given the references and you have given all your polls. His waist circumference, lean fat Indian, which I was couple of months back. Now, these are certain facts which we need to look into a patient walking into our clinic every day. Is a triglyceride waist phenotype. Now, this is triglyceride multiplied by weight. If you calculate this patient is 18,000, which is 10,000 and under for a male and 12,000 and under for a female. This is a normal reference for every patient walking into the clinic. Now this is triglyceride by waist ratio. This patient is 1.9. The cutoff for a patient is less than 1. Anything above 1, this is triglyceride by glucose ratio. Anything above 8 is below 8 is a low risk. About 8.5, we look at this patient to be high for everything, for metabolic syndrome. Now this is triglyceride divided by glucose divided by waist ratio. This is 915. The normal is less than thousands. I don't know. Thank you, sir.
Okay, so I needed Vaishali to just introduce this case. Now listen. Out of all these parameters, these sound complicated, but they're easily done in the clinic, and I need you to pay attention to 2. So everyone knows the Maxwell silver hammer, right? So what was the Maxwell silver hammer? Go down to the Beatles and go down to something catastrophic that was to come. So this is simple. You take the waist, 80 centimeters for a female, 90 centimeters for a male. You take the triglyceride. Now, I want all of you to remember your triglyceride cutoffs that you all think is normal. I want you all to simply take the waist and take the triglyceride. The purpose is identifying the fat that the sarcopenic diabetic obese person has. 50% of the diabetics who come to your clinic are visually non-obese. What does that tell you? There is some obesity that's driving the pathophysiology. That obesity is your visceral fat. I'm trying to make you think of how you can use a clinical marker in identifying the visceral fat so you can start risk assessment on an average 7 years before you can actually start risk assessment. So you don't have to see 7 years of diabetes, you don't have to see 50 years of age, you don't have to see the HSCRP, you don't have to see a leaking kidney because you know there's a strong relationship with heart failure, with ischemic heart disease. I'm trying to go one step beyond and make you identify these people far earlier. So coming down to these cutoffs, if you take the triglyceride and a simple waist circumference, 12,000 for a man, 10,000 for a female. What is this gentleman's number? I want you to remember these two numbers. Whenever you have triglyceride, you add a glucose to the triglyceride variant, you're changing the specificity and the sensitivity of picking up visceral adiposity from 65 to over 85%. That means the chance of you picking up visceral adiposity just by using one marker, adding the waist-hip ratio or the weight-height ratio, which anyone in your clinic who's doing your blood pressure parameters before they come in, you add these three parameters, make quick calculations in your head, which doesn't take time. You have got the ability now to identify visceral fat. This visceral fat number is generally under 100 for a man and 90 for a woman. Visceral fat, I want you to look at three aspects. I want you to look at the liver. I want you to look at the epicardial fat. The paracardiac fat, unfortunately, there is an association with the risk of mortality, but by reducing it, there is no association of mortality reduction compared to the epicardial fat. I want you to look at the kidneys from two aspects. So the epicardial fat is 20 to 40 mils. I want you to look at the kidneys by the perinephric fat. I want you to look at the renal sinus fat. So anywhere from 5 to 9 millimeters for the perinephric fat, some groups 5 to 8, some 5 to 10. And the renal sinus fat, anywhere from 5 to 8 to 5 to 10 centimeters square. So the thinnest of them all is the perinephric fat. I want you to look at the perinephric fat as the starting point to nephropathy. And I want you to look at sinus fat from the progression of nephropathy. For every 10 centimeters of the waist that increases, 10 centimeters, visceral fat increases 18 to 25 points. And urine protein will increase by 30 points. Why is 30 and 50 important? Because when you bring the UACR down by 30 points, you're looking like at a cardiovascular risk reduction of 23%. When you bring it by more than 50%, you're looking at a cardiovascular risk reduction by 29%. Now I'm going to try to introduce you to the associations of visceral fat with all-cause death, with MAFLD, with cardiovascular disease, with stages of nephropathy, and the development of incident diabetes. So, taking my numbers, I've introduced you to today's topic. Now let's try to grab each number with evidence. How many of you would introduce or would like to further reduce this triglyceride of 190? Understand they're on fenofibrate, they're on 10 statin. You all know the statin story, the triglyceride story, you know all the stories. I just want a raise of hands. How many of you, after what I've said, would like to bring this triglyceride down further? So yes for raising your hands, no for the people, don't raise your hands for the ones who are no. So we have 1, we have 2, 3. My dad wants to lower his triglycerides. So my dad's triglycerides were 224, they are now 110. Okay, so my dad, Rishi, my mom, my daughter, Vaishali, my third daughter stuck to me, Aisha, Dr. Chandra. So we have, I'd say, 1 in 10 in this room who wants to further lower this triglyceride. And so, you want to lower this triglyceride? Okay, sorry, I didn't. Sorry. So we have the whole first line who wants to raise, Dr. Deshpande included. And Dr. Deshpande wants to do it because his nephropathy drives the liver to produce greater LDL. So he's doing it from a vested interest because that's part of his therapeutic protocol, because if he wants to protect his nephropathy patients. So we have 1 in 10 who wants to do it. Now, I want you all, Suraj, do we have a Q&A here? Is Suraj there? Are, Bhagya? Okay, anyways, show of hands. So who wants to add saroglitazar or replace fenofibrate with saroglitazar? Who wants to encourage, are we doing a Q&A here? Okay. Who wants to encourage exercise in the ADA protocols? 150 minutes per week and strength 15 to 20 minutes 3 days a week. Refer to a nutritionist. Increase the statin. Use a GLP or a GLP-GIP analog. Use 2000 milligrams of icosapent and none of the above. Can we start with the first option, saroglitazar? Who would add or replace? So we have again 1/15 of the crowd. Encourage exercise, and these are one options, okay, not more. Not more, one options. So exercise, exercise cardio. Who would like to do that? 1, 2, okay. So we have, and I'm going to ask the ones who raised the hand as to what type of exercise you'd want to do. Okay, that's the catch. Refer to a nutritionist. Okay, that's okay. My mom as my chief nutritionist, fine, but anybody else is a catastrophe. I'll show you nutrition data, how nutrition can lead up to 8 kilos of weight loss in 12 weeks. The muscle loss is 3 times more compared to people who don't exercise. When they gain the weight back, which they will gain in 9 months to 37 months, it's only fat. So they are killing all your patients, and I've stood by that for 20 years. Okay, and the evidence I will show you again. Do you want me to give you percentages behind each of these numbers or for later? What each one would do? Okay, fine. Okay, now therapeutic options. Basal bolus. So just add basil at bedtime for this person because you're trying to get the fasting sugar down. But you'd also know insulin affects the peripheral metabolism of triglycerides and has shown to improve 10% decrease in the triglycerides just as an independent molecule, right? From the peripheral lipase activity. Add pioglitazone. Who wants to do pioglitazone? 1. Tirzepatide or semaglutide. Options. Okay, so tirzepatide, who wants to do? Semaglutide, who wants to do? So we have semaglutide only 1, 2. Okay, we have only 2 for semaglutide. Encourage, what was the last one? Sorry. Yeah. So keep to the same and encourage only strength training in the gym or none of the above. Okay, I want you to keep these options in mind. I'll come back to these options at the end. So now, what is ABCD? In a nutshell, it is basically chronic disease. It's an organ today that stimulates and perpetuates disease and leads to a chronicity. This is physiology. Muscle loss starts at 40 years of age and fat keeps building till the 7th decade. This is physiology. This is how the body is designed. Okay? I will show you as we go on through the next 2 talks why the Indian body or why the Indian phenotype is different and how it loads to body weight. So unfortunately, our physiology is responsible for fat accumulation and muscle loss after 40. Now, the cardiologists always stood by weight being one of the most potent risk factors. I think we all are in consensus that when your BMI is above 35, you don't have to worry about fat, you don't have to worry about visceral fat, because there is a strong correlation between BMI 35 and above with all the other fat compartments. So that is a no-brainer. But when it comes down to a BMI under 35, that's when the problems start. Do you look at the weighing scale? Do you look at the body fat? Do you look at the visceral fat? Is there any way we can differentiate all clinically, which is what we're going to take this journey forwards. So the paracardiac fat, I told you, was a fantastic correlator to cardiovascular mortality. So for every one standard deviation away from the paracardiac fat, it added 34% to the risk assessment of cardiovascular mortality over and above the CAC score. So you know the CT coronary calcium score's importance. We know it's a great tool. We know it has a great negative predictive value above 90%, but the positive predictive value is 79%, which means that if they have a normal value under 100, there could still be a 21% chance that it could be significant. So please keep that in mind. Don't just think that a CAC score is under 100, so the guy is safe. What we do is, we do several other markers to make sure that we get it over 97%. And if you want, I can tell that to you at another time. Now I want you to consider the obese Asian. I told you 50% of these are visually normal when they come to us in our clinic. This was the masala and the MISA studies. You know all the MISA studies, right? The masala was another name given for people who looked at the different ethnicities, because in the LA and the Chicago area, they looked at the South Asians. And what they found was, compared to the other communities, no brainer, that the muscle mass was significantly lower than the fat mass. They had much higher leptins, much lower adiponeptins, and they had an inflammatory marker, which is your resistin. Resistin comes from the word resistance to insulin. So what do you mean by resistance? How does it resist insulin? It basically autophosphorylates the serine protein of the IRS. So which means that anything that down regulates through IRS, you all know IRS, right? Your AKT, your mTOR pathways, your DS160 transporter protein that translocates glucose, GLUT4 for insulin sensitivity, this all gets destroyed. And it diverts this to the to the mitogenic pathway, which is your MIP kinase pathways. That means it encourages growth. It encourages inflammation. It encourages toxic radical formation. I want you to consider the South Asian phenotype with the white phenotype. So for every marker, we have a distinctly greater fat compartment. So if you look at the triglyceride prevalence, this is 1.3 at a value of 150, but I'm going to redefine this number for you. So the average serum triglyceride for the same weighing scale is 26 to 38 points higher for an Asian. The BMI is 2 to 5 higher. The body fat is 6% higher. The abdominal circumference is 5 centimeters higher. The lean muscle mass is about 3 to 3.5 kilos lower. And the prevalence of metabolic syndrome is as much as 2 to 3 times higher. So is this a genetic thing? I'll show you a study and explain this to you. So I told you, look at visceral fat in these 3 ways. A pictogram to show you the types of fats. So I told you the renal sinus fat, the perinephric fat. I show you through a diagram the longitudinal section of where the renal sinus fat is actually located. That's right in the center, the yellow stuff. And the pericardiac fat, which is basically, it bathes the surface of the myocardium and it bathes the blood vessels. Now why these are unique? Because think about, there's direct mechanical compression of the organ. As it keeps growing, it blocks the arteries to there's congestion. Because it is in touch with the arteries, it acts as a paracrine organ, exchanging inflammatory markers. It activates the RAS system. We know that the RAS is both local and systemic. We have managed to deal with systemic RAS, but we do not know how to cut down the local RAS, which is why kidney outcomes have not changed over the years, especially death outcomes. So you give an ARB, you'll reduce a kidney outcome, you'll postpone a kidney outcome, you'll slow a kidney outcome, but you're not going to change death. And we know from blood pressure studies that death actually changes when you control the blood pressures and identify the reverse dippers, which are 63% of diabetics who raise their blood pressures between 3 and 6 in the morning. So this is the so in a nutshell, the Asian has 10% more visceral fat than the Caucasian. I've already given you the numbers. Why is it important to redefine triglycerides? As the fat expands, it releases free fatty acids. This is nothing but your triglycerides. Resistance increases, the triglycerides increase. Your diet goes to the liver, VLDLs 1, 2, triglyceride rich, CETP and LCAT send it to the HDL and the LDL. You're making them less buoyant, you're making them small, you're making them atherogenic, you're making them toxic. We always knew that studies and observations showed triglycerides are outcomes. But I always believed is we caught it too late. The highest triglycerides are actually between 7 and 11 o'clock in the evening. It takes 11 years for it to translate to a fasting level. So why the hell have we been doing fasting triglycerides for donkey's years? We've just got the whole math wrong. So Vaishali, the Ravan, right? The Ravan, so we call this the Ravan in our clinic. Until we don't get the Ravan down, you're not basically going to help your outcomes. This was our paper. We published 2 posters last year, the ADA. We showed that. So we tried to look at the triglycerides. We found that when we did the FIP scores had a 0 association with finding out fatty liver disease. What we found was that we had up to a 70% sensitivity and specificity for a triglyceride of 128 for picking up F2 to F4 fibrosis. And if these people had liver enzymes above 50, the chance increased 3-fold. So just by doing the fasting triglyceride, looking at the liver enzyme, even with normal liver enzymes, understand liver enzymes cutoffs are now 25. Even with normal liver enzymes through the reference ranges, re-look at the whole thing, calculate the triglyceride, look at the phenotype, look at the triglyceride, make a quick evaluation, and you will pick up visceral fat as early as that. Now, what we did was, in the same cohort, we looked at the NT-proBNP. We found that at F4, the BNP was significant. That means Indians have a shared pathogenesis between the liver and the diastolic dysfunction of the heart. Now, in the Western population, this is different. When you have a liver that's fibrosing, what do you expect? You expect portal pressures, you expect varices, you expect rectal ectasias. You're diverting that blood somewhere else. So what should happen to the venous return? It should actually reduce. So what should the BNP? It should actually come down. That is what is seen in the Western population. So I've always told everybody that Indians are different. Please use your own numbers and guidelines to treat them. And I'll show that to you in my third talk. So the association of triglycerides with all the different fat compartments, and concentrate on the pink range, the lean, sarcopenic, obese, diabetic Indian. So you have got a 2 to 3-fold increase in the fat compartments. As you progress overweight to obese, you see the fat compartments increase tremendously. For every 10 points above your reference ranges that you decide, I told you the fat compartment of viscera will increase by 18 to 25 points. And that's a lot. That's huge. That's as much as 1/3 expansion of the fat compartment in the viscera. And that's not funny. That's not funny on any level. I will explain to you how this triglyceride is associated with muscle loss, muscle wasting, and functional loss. And the data is for every 10 points, there's functional muscle loss of 1 to 2%. And at a value of 180, the muscle starts actually dying and the power starts coming down. So view it as fat more than muscle, right? So what are we trying to look? Visceral fat. Look at your clinical indices. Anything that is triglyceride based and glucose based will give you an accuracy of over 85%. You add the waist hip ratio and the waist height ratio, you'll get an accuracy of over 90% association. So now think of that 32-year-old who comes to you on an annual blood check, who's got a triglyceride of 225, who's big on his waistline, who's short, and he tells you who's got a fasting insulin of 20, and he wants advice from you. Is he willing to learn that this is the start of his death? Right? So you are able to now translate his longevity at a far earlier stage of life. The best ways to detect this is the MRI, the DEXA, and the CT at level L3 and L4. The triglyceride to the visceral fat, I've explained this to you. There's a correlation with all types of mortalities. I'll go a little forward. Now this is the silver Maxwell hammer. So if you use the waistline and you use the triglyceride, it outperforms the waistline, and that outperforms the serum triglyceride. So if you just use one of these numbers, you get a 30-40% chance of visceral fat. But if you use both these numbers, you've got up to an 85% chance of picking up visceral fat. A normal person's visceral fat should be less than 15%, and up to 25% is what you will accept, nothing more than that. Very good risk assessment for incident diabetes and liver disease. The others, when it comes down to the kidney, the cardiovascular mortality and all-cause mortality is up to a twofold, but it's much more predictive for liver fat. Now the triglyceride waste. What were the cutoffs? I told you, 12,000 and 10,000, right? Look at when it's above 15,000. What was our number? 18,600. You've got an 85% and above chance of picking up visceral fat. Look at the MAFLD. Now, if you add glucose to this equation, it becomes 7-fold predictor for MAFLD and over 90% for visceral fat. That is the strength of adding glucose to this value. What are the cutoffs? 760 for a female and 830 for a male. What was our number? 916, right? Huge. Is that worrying all of you? Ask you the question again. Who will lower the triglyceride down further? Do I have a greater show of hands right now? A greater show of hands? Yes. Let's move on. Okay? This is another triglyceride ratio. This is a little complicated because it's triglyceride ratio by log, and we don't carry scientific computers in our clinic. So if you do the waist hip ratio, waist height ratio, and the triglyceride waist, you're good enough. So in terms of performance, who performs the best? The triglyceride glucose waist, followed by the triglyceride glucose, then the phenotype, and so on and so forth, right? Who performs the best in terms of anthropometric parameters? BMI is useless in our country, so please don't use it. The waist hip ratio, the waist height ratio at the same level, the waist circumference, and the percentage body fat, but we all use the bioelectric impedance, which is not the best. So if you don't have a DEXA and if you don't have an MRI, that's not the best. And you can't be asking your patients to spend 3,000 and 5,000 and 10,000 on an MRI when you can get the same information on a waist hip and a waist height ratio, which takes no more than 5 seconds in your clinic. So I'm trying to make you rethink how to evaluate these people. So let's say somebody has a fasting glucose of 96 and they show you an insulin of 16. You don't have time to do the HOMA score. He's got a waist. Every person coming to your clinic is going to have a waist above 90 centimeters. Look at his fasting triglyceride. You know, and if his HbA1c is above 5.5 by the Endocrine Society, and 5.7 by the Diabetes Society, do you have an argument for saving his life? You will find that 7 out of 10 people will fit this category, and you will start risk assessment 5 to 10 years before disease translates. Okay? And this is the order of the day, right? I want you to look at muscle less than fat, right? Look at the association, 130 triglyceride, myostasis begins. 180, you start getting sarcopenic diabetes with functional muscle loss. That means, I told you for every 10 points, functional muscle loss is 1 to 2%. Now the question remains is, what types of muscles are affected? Think about your type 1 muscles as your basal insulin uptake. Paraspinal muscles, lower limb muscles. Think of the 2 fibers being metabolically flexible. You can move them to type 1. You can move them to type 2X. Type 2X muscle is in animals, the leopards, the cheetahs. My daughter, who's India's fastest swimmer, our Olympian. If I checked her muscle, she'd be type 2X. Type 2X muscles are only glucose dependent. So fast, ultra fast. So that's why they have short bursts of 60 to 80 grams of carbs before a race. Because they want to optimize the X. 10% of your quadriceps contains X. So if you look at your lower limb, do you expect your quadriceps to fail the last or early? You expect them to fail last in somebody who's exercising because they have the ability so the quadriceps, even though it's type 1, it has 10% ability to develop into type 2X. So if you look at the distribution of muscle loss, go from down to up. Gastrocnemius soleus first, hip abductors second, the gluteus third, the quadriceps fourth, and your hand grip along with your abductors. Have you all tried to squeeze a diabetic's hand? Try it. I do it to all my patients. You will find that their proximal muscles and their hand grips, they will not be able to squeeze your hand at all. So can they climb stairs? Can these people climb stairs? No. Can they get up from a chair? No. Can they hold a railing tight when they are imbalanced? So what are they going to do? They're going to fall. And they're going to fracture their hips. And that's the end of their story. Because you know death is 90% within 5 years of somebody who fractures their hip. Right? So when it comes down to our patient, what was his waist triglyceride ratio? 18,000 and above. See what happens at 15,000 and above to functional muscle loss. Look at the last column. You have 40 to 60% of loss of strength. Now this 1100, our triglyceride glucose was 916. So look at what happens at 1100. You're having 40 to 60% loss. But this 1100 is equivalent to the 960 of a nation. So you're looking to strengthen their muscle tremendously. What do all of us do when somebody has weakness? We check their vitamin D. We optimize their vitamin D. That will only increase 5 to 6% of their strength. And when they come back to you, they say, I'm feeling good, but they're still weak. So understand, it's a part of the disease process. What is the role of GLP? This was a great study. So there was an arm that was calorie deficit, 700. Only diet, that's your nutritionist. Diet with exercise. And the third arm was only exercise. People who exercise, they lost 2 kilos and they gained 2 kilos of muscle mass. The people who dieted and people who dieted with their exercise, they both lost the same weight. around 8.5 kilos. But the one who dieted lost 3 times more muscle mass compared to the person who exercised along with dieted. And that's me. So muscle loss was minimized by my 110 grams protein intake. I didn't let my hair fall. So my hemoglobin, my ferritin, my beetroot juices, I maintained my basics. So I would not injure myself. So I got reduction in back pain. I got reduction in leg pain. You know the ratio of body weight to knee is 1 to 1.2 is 1 to 2.4 to 4. That means if you drop 23 kilos of weight, you've got a 50 to 80 kilo weight reduction effect on the lower body. And that's massive. Now to these people, we gave semaglutide. When they gave semaglutide, you know, at the new step-up doses of 7.2, I'm not going to talk about the 1 and 2.4 milligrams that you all know. I'm going to give you all the data of what you all don't know. At 7.2 milligrams of semaglutide, 15 days, you have up to a 19% weight loss. You have 24% reduction of body fat, 10% reduction of intramyocardial fat, muscle fat, goes away. You have 11 centimeters more waist reduction compared to the 2.4 data. So despite muscle loss, when they did the SF16, 36, which is the quality of life questionnaire, their quality of life improved and their physical fitness improved despite the muscle loss. The same exactly was seen with tirzepatide. Tirzepatide traditionally, because we don't have head-to-head comparisons, the traditional data is you lose the muscle mass. They say the muscle to fat ratio is 1:4. Semaglutide says 1:3. But again, don't listen to the data because that's Western data. You use me as your benchmark. And one of my motivations for doing what I did was this talk, because you're going to get the world's first head-on-head comparison in my third talk between semaglutide and tirzepatide. We are going to expand that to greater numbers, but I had to do a propensity score matching and a Bonferromi's correction. So there were too many parameters that we had to match. So on a nutshell, bariatric surgery, right? You know the diversions, the bypasses, you know the banding. You know that up to 26 kilos of weight loss through bariatric surgery, 40% of that was loss of fat-free mass. Fat-free mass equals muscle and bone. We know from that data that the women benefited most with a 40% reduction of breast cancer. And that's going to be my second talk on diabetes, cancer, and the role of GLPs. Okay? Now I think you all are sick of hearing me. Okay, the last slide. This is my take on in an Indian diabetic who's sarcopenic. Can you give a 10 milligram tirzepatide to this fellow? He will fall and die. Can you give 15? He will fall and die. Can you give 2.4? He will fall and die. Can you give a 0.5? Yes. Can you give a 2.5 tirzepatide? Yes. If you want to achieve the jab. Can you give 5 with caution? Can you give 1 sema with caution? I'll tell you why these numbers are relevant in my second talk, or my third talk actually. Okay? On that note, how do you improve sarcopenia? Resistance or strength training. Focus on the muscles that the abductors, your glutes, your quads, and quads a lot because you can change it to an X fiber. So you'll get much more stability. Gastrocnemius soleus, that can all be done. Raises in the chair, side raises in the chair, and sit on the chair on your squatting. They don't need to get up. They can do it on their office chair. Take a gripper, buy a gripper 50 times. Simple, easy, done. You've saved your patient's life. Okay? Obviously get the right protein, but you know limitations in diabetics, you really can't cross 0.8 to 1. Lucky we are vegetarians. so we don't get the protein. So you can safely add the vegan protein. You know the value is 70%. I use a lot of creatine in my practice. Creatine is amazing. It's just ATP. Don't get scared. Bodybuilders use creatine. That's a myth. Okay? Creatine is a fantastic substance. You have to know how to cycle it. You have to know how to use it. Okay? You have to use it in 1 to 3 grams, not more than that. Hydrate them and cycle it. Means 5 on, 2 off. 5 on, 2 off. 5 days a week, 2 off. 5 days a week, 2 off. You can cycle it monthly. You can cycle it weekly. I'll discuss that later with you. Always keep an eye on the kidney functions. Now coming back to my last question. How many of you would add saraglitazar to this patient? I'll tell you why it's irrelevant. Understand fenofibrate and saraglitazar both predominantly work on the similar axis. It's your PPAR axis, your alpha, your gamma to some extent. You're not going to get a dramatic response. Okay? Exercise. In diabetics, the data is 15 to 20% response. You can go up to 30% if you get it really right. But again, exercise, understand, is not just exercise. It is achieving 80% of your heart rate. If you achieve 80% of a peak heart rate for at least 17 minutes, that is when you start getting the triglyceride response. Minimum 3 to 6 weeks with strength training. Nutritionist, you'll get the triglyceride response by, I'd say, 50%, but you are creating long-term health benefits. If you go from statin 10 to 20, you'll get a 6 to 8%, and this data we have with rosuvastatin. Use a GLP analog. In our data that we had from the SEMA, these were not diabetics. We got a 12% reduction in triglycerides due to the weight. But the data for tirzepatide and semaglutide for 7.2 and 15 is up to 40%, so 25 to 40%, okay? The data for the 0.5 and 1 milligram versus the 5 milligram is about 12 to 20%. So you can, that's still not too bad because I've given you numbers of tens. The tens go up and you get functional loss and sarcopenia. Therapeutic options, tell me now out here, who would add tirzepatide and who would add semaglutide? So raise of hands for tirzepatide. Who would add tirzepatide to this patient? Nobody. Oh God, did I send the wrong message? Okay, we have one starting. So listen, the message is please use these drugs. But your prerequisite is they have to strength train and they have to eat their protein right. Okay, don't take away mortality reduction. Because that is the whole reason you're treating them. For the ultimate endpoint, what is the ultimate endpoint? Death reduction. Quality, sorry. Death reduction. They're not paying you a fees for quality of life. They're paying you a fees for, listen, I heard diabetes kills me. I want to reduce my outcomes. Okay? Rishi agrees with me. Conclusions. Lots of conclusions here. Okay? I'm not going to bore you. I'm going to move to the next topic because we have 2 and I have to preserve my voice. Thank you so much. Who's next?
Thank you, Vishal, for a very interesting talk. I think it opens up a lot of possibilities in a lot of minds, and I'm sure there will be questions for you.
So one question.
So here we have the first one.
So yeah.
One moment.
So clinically we have seen statins plus saroglitazar versus statin plus fenofibrate. The reduction in TG is more, sir, clinically, with saroglitazar.
Agreed. The data is 70%. The data we have is 70%. So when I have a triglyceride of, let's say, 2000, we can predict through our numbers, from 2000 we can get them. So my last patient, triglyceride, that's my pharmacist's husband. Routine checkup triglycerides were 1,000. 1,000 how much? Tarun was 1,000, 1,100, right, Vaishali?
Yeah.
Tarun, 1,100. 1,100 triglycerides. In 4 weeks, we got it down to 111.
With?
No, that's my trick. I can't share my tricks with you. Hello. Yeah. How will it be harmful? In fact, so The
But
only
have you
data
tried
we have-
with-
The only data we have is with.
No.
Thank God. But you see,
Sir.
the chance, again, the data with triglycerides and pancreatitis is not in the percent, is not in the 10s and 20s and 30%.
Sir, how
It's in the 2s to 5%.
So have you
So diabetics just have a threefold increased risk of pancreatitis because we've been looking at the triglycerides at the wrong time. If you do a triglyceride at 11 o'clock in the night versus 1 o'clock at night, you will find a 70% difference minimum, 50 to 70%.
any data with familial triglyceride?
For the numbers. So we get them down to between 200 and 400 from the 3,000 and 5,000 numbers. So to get them down to below 200, they have to become me.
Yeah, yes, gentlemen.
You were to comment on my choice of giving PG and
So from this, what did you realize? So A is they have a you see that they have a reciprocal relationship. Every time your triglyceride actually comes down, your HDL goes up. Okay? You are not really interested in the HDL. It's such a complicated story. You're interested in there is a qualitative and there is a quantitative analysis. I'll tell you why. Because when we went to increase it, and we did it through our CTP inhibitors, people died with thromboembolic disease. That is why all the trials stopped. So the only way you can increase it is by cardiovascular training, but your heart rate has to be between 80 to 90% of peak. The only way you can increase it.
I think for triglyceride, how many hours of overnight fasting? Because
No, but that's what I'm saying. But that's what I'm saying. That whole concept is wrong.
So we're doing it all incorrectly, Vishal.
That whole
We should
concept
be-
is wrong.
We should be measuring postprandial levels.
You should be measuring it non-fasting after a meal.
That's what we should be doing, yes.
One is that triglyceride, should we do anti-pro-BNP in all diabetics? That's my question.
So I'll talk to you later on that and on all my studies. So we have studied this for 20 years. Right from 2017 to 2026, we have multiple papers on this. So when we optimized our patients, we optimized 200 people followed for 2 years. We brought all their numbers down. We couldn't only do one thing. We couldn't bring the anti-pro-BNP down. So 39% of those 200 over 2 years, we are talking about LDLs of 40s and 50s. CRPs come down by 200%. We couldn't change that. But that era is changing because with the GLPs, with the SGLT2s, with the optimal statin, we know that from the GC heart failure, when they used only 10 milligrams of rosuvastatin versus 40 milligrams. So if you go from 10 to 40, you see your BNP, it drops by 20%. But again, if the TSH jumps twofold, your BNP will increase by 12 to 15%. So it's not that easy, but yes, you should do it because we don't measure left ventricular globular strain.
Yes.
Once you start measuring the left ventricular globular strain, you'll realize that all the people above 20%, there's a direct correlation with the BNP matching. And that's far before diastolic dysfunction starts. So we are looking at all the wrong markers. So if you actually start doing the visceral fat in this patient, if he had come to you as a non-diabetic, you would see his left ventricular globular strain, it would be above 20% in 7 to 8 out of 10 patients, which is what we are looking at.
Great. The second thing is that should we start measuring triglycerides at 7 to 8 p.m. as you had suggested?
I always do it non-fasting, always. But problem I have is that you want your other renal profiles and you want your others. You know there's a circadian rhythm with creatinine. Absolutely. And these idiots do the picric acid method. They don't do the enzymatic methods. So a lot of the other tests that we and you can't tell them to prick them twice. One morning, one evening. So I usually find a middle ground. What I do is, if you test your simple creatinine versus fasting versus 12 o'clock versus 3 o'clock, you'll get a variation of up to 12 to 15%. And that's not good for your interpretation. Because the moment it rises, EGFR drops, you're going to adjust the other Rushi is sitting looking at me. He's like, ये बात कर रहा है. इधर कोई nephrologist नहीं है, तो इसको बात करने दे. Am I right or wrong? हाँ. Am I, so this is basically what I do. And I think apart from a few labs, all the other labs are saving money and doing the picric acid alkaline method rather than the correct methods.
The other thing is that Anyway,
But I
we
do
are-
cystatins in all my patients, so I have a relationship.
Anyway, we are doing non-fasting lipid profile now. So would that be a good marker in any
Yes.
case, better than fasting?
It would overinterpret the fasting, I'd say, with the first meal by 20%. And you would have a higher than normal value. So unfortunately, all these numbers are on fasting.
Yes.
So coming down to the gentleman who said below 100, he's actually right. Because if you're looking below 100 fasting, post meal is going to be 130.
Right.
So the gentleman who said 100, and Bipin sir would have said 100 too. We had a talk yesterday. So Bipin sir said my target's below 100. For everything. man. I'll tell you that. We are looking at that data. No, there's something in the case that I highlighted. I highlighted something in the case. Did you notice the FOB? Did you notice the LDL? They were discrepant. If you did a calcium score in this guy, it would be more than 200. So we are looking at the data and giving you optimal values. We'll probably publish it next year.
Okay, last question.
Can we have a concept of post-lunch blood sugar with post-lunch triglyceride?
Absolutely. But again, the same concept of if you're combining it with other blood tests, patient can't be bled twice. So I've chosen a middle ground for non-fasting around the 10 o'clock when they go to the office. I tell them, call your blood lab there and do it there.
All right. Thank you all now. Thank you, Vishal. You generated a lot of interest in this situation. Very, very interesting material that you told us.